Welcome to Care Beyond Barriers, where we will explore some of the biggest issues facing healthcare today and how technology and AI can make an impact. I'm Christina Farr, a health technology writer and investor, and today I'm joined by Dr. Tom Kelly, Dr. Hannah Allen, and Dr. Simon Koss. Given that we're such a global group, we've got US, UK, Australia. I just want to do a little bit of a scene setting exercise to talk through what we are seeing globally in healthcare and then where you see the biggest challenges. I'm going to start with you, Tom.
Sure. Yeah, I think I'll talk from maybe the global perspective because I see all the different countries we operate in at Heidi. So universal capacity constraints, the complexity of delivering care has increased a lot, lots more conditions, lots more investigations, people are living longer. So you've got this growing idea of what gold standard care could be. And then a workforce that is getting increasingly underfunded and finding it difficult to actually manage these chronic conditions as our population ages. And so pretty much everywhere we see that, I guess, supply-demand mismatch where, waiting lists are growing, patients are finding it harder to get in to see their normal clinicians. And obviously that's where we try to build tools that increase supply without needing more headcount or more workers.
Hannah, do you have any thoughts on what the golden age of medicine may have been, and how did we get to this point where we seem to have strayed so far from that?
We've seen things change rapidly over the past sort of 5 years, and through sort of COVID and the pandemic, we saw some really great sort of adoption and innovation and some really positive changes from the healthcare front. But since then, because of a lot of the challenges that you were referencing there, Tom, and the kind of complexity of diseases that we're seeing, the comorbidities that patients are presenting with, along with that sort of, overstretched, under-resourced, human resource. As a GP, when I'm seeing patients now, it's almost impossible to see a patient within the kind of 10-minute constraint that is sort of forced upon us. So it's really, really challenging environments that's leading to this kind of low morale and kind of workforce challenges that we're seeing. But also, I think the role of the doctor has completely changed. So when I see patients now, I'm seeing them for loneliness, for mental health problems, for, their complex disease management, for all these different challenges that typically would have been deemed in healthcare, but maybe associated with like socioeconomic challenges that we're experiencing as a population. And I think along with rising expectations from patients with this change and evolving role as a doctor now, is leading to other more complex challenges as well. So I think it's a really tricky sort of evolution of healthcare that we're having to try and navigate.
And you mentioned less time, so 8 to 10 minutes being the normal patient consult. And then at the same time, patients with a growing set of needs that are incredibly complex. I talk with physicians who tell me it used to be you'd meet a 96-year-old and it would be so abnormal that it would be talked about amongst your fellow physicians and peers. And now you might meet 5 on a typical shift. So Simon, walk us through what that experience has been like for physicians that are caring for patients who are incredibly complex, incredibly frail, and with such limited time.
It's such a challenge as a clinician, regardless of how long you spend at medical school. You get out there and day one, you're on the floor and all of a sudden you're learning things in practice. And that practice is changing on a day-by-day basis. That kind of means that you need to be reading 28 hours a day just to stay current. How can anyone do that? And that bleeds into how can you provide good quality care in such a rapidly changing environment, and what does that mean for the workforce as they keep up? And so, yes, it is the complexity of the patient conditions as people are living older and they've got more complex chronic disease, but it's also the plethora of different interventions that we've got and treatments that we have, and the subspecialisation of healthcare, which means that the team is a whole lot larger. So I think digital's got a role to play as the glue in helping individuals who are constrained by those human constraints. How can we bring people together? How can we surface evidence? How can we make sure that the care that we're providing is appropriate for the outcomes we're trying to achieve?
We've all mentioned chronic conditions. And globally, this is a huge problem where people with chronic conditions who are represent a larger and larger segment of society overall are responsible for the bulk of healthcare costs. Given medical training, in the US, it's, for physicians, it's very limited that they even receive any medical education whatsoever around nutrition. Same is true for many other countries around the world. Do you think the training that we're giving physicians today is giving them the tools and the resources to be able to treat patients with these chronic conditions where there are such strong lifestyle factors? Tom?
It's tricky because I guess you have to teach like the pathophysiology, like how do conditions come about, how do you make a diagnosis? I don't remember many lessons on management or you kind of meant to learn on the job, I guess. And half of the battle for me when I was practicing was always coordination. Like, how do you actually get a patient to go see the 5 people that are involved in their care where, and I only have like the 5 to 10 minutes that I'm with them to help make that plan. So yeah, I think there's definitely a role for lifestyle interventions. That's where even things like GLP-1s and other things are such magic interventions because they're low effort and they're not hard. But most interventions in management are not like that. It's complicated. It's hard to get them to actually go and do all the things that will minimize their risk or make sure they have a better outcome over time. So yeah, I don't know what the right answer is, but it's tricky.
There's a lag, isn't there, from what you're learning at medical school, to now what's current, right? You that's why we have to practice kind of continual professional development and, demonstrate that in our appraisals each year, etc. But I think that our knowledge and understanding of stress and sleep deprivation and all these very basic things and the neuroscience and how that is impacting on our kind of physical health, that's massively evolving. Hormonal health and women's health, we have not really ever understood, and we're still learning now, the effects of the perimenopause and the kind of gut brain link, etc. So all of this has really evolved over recent years, I would say. And there's a lot of research and evidence to support delivering healthcare and kind of well care for patients with chronic disease in different ways. So in the UK, there's some really interesting stuff around compassionate care in primary care, where they'll get patients doing gardening or, thinking about engaging with their kind of communities alongside of traditional medicine. And they see this huge decline in unexpected A&E attendances, for example. So I think we're in this sort of pivotal time where we're starting to embrace other alternative ways of thinking about how we deliver more traditional healthcare to be able to manage this overwhelming, volumes of patients.
So on the one hand, it's all getting more human. It's getting more integrated into community, connected with our social lives. And on the other hand, it's technology. And you mentioned it as being the glue. So I would love to hear your perspective, Simon, and somebody who's worked much of their career in bringing technology into medicine. How do you see the variation in how physicians across the world think about technology? Because I would imagine now we're at this point where you've got a cohort who thinks it's, bad writ large for all sorts of reasons. I mean, technology moved into our lives, and the first thing that many doctors grappled with is electronic medical records. And there is a strong argument to make that it made things much harder as a physician. So there's that cohort, and then you get a cohort, which may be all of you, that really believe it's incredibly valuable and want to be using technology and especially AI in their day-to-day lives. So how do you kind of thread the needle, and how do you get physicians on the same page?
So I'll date myself. When I was practicing, things were on paper. And even then, we had an emerging digital society. And I felt like when I came to work in the healthcare system, walked into hospital, I'd kind of check my brain at the door and walk back into a different age. We had problems then. They were different problems. And we used simple technologies like systems of record, not just the electronic health records, but a whole bunch of diagnostic systems for pathology, radiology, the patient administration systems. And in putting those systems in, we did some good. Things became legible, they became accessible. You got economies of learning as people went to the same system between different facilities. But we also took something away. in asking clinicians to move from the elegance of paper and pen, where you could efficiently get around to your patients, you kind of stepped backwards and became a data entry clerk. So there's a whole generation of clinicians out there in the workforce who see technology as a disabler rather than an enabler. And I've certainly seen that through my digital health career. One of the most exciting things now about the time we find ourselves in is the technology that we have has caught up with modern society. You mentioned artificial intelligence, but I call them systems of engagement, the kinds of natural user interfaces of getting information in and out of systems. That's what can make a huge difference. So despite the cynicism, and there's plenty there, and those systems still exist that create friction in the care process, I think there are a whole raft of new technologies that are really exciting and are going to make a huge difference to patient outcomes and clinical experience.
Tom, I'm going to press you on this because we're talking about this sort of cultural change that we're seeing now, where physicians are finding that technology that used to make their lives worse, now there are potential solutions where they can almost get back to a style of medicine that is from this era, the clipboard era, where they could really talk to the patient. But there's still, studies have shown that there is still some resistance, that it's perceived as, lazy, that somebody would look something up while practicing seeing a patient, or that they would use AI tools like Open Evidence or Doximity instead of just having that knowledge immediately accessible to them. And then you meet with physicians who feel the opposite, that in this day and age, how could you possibly study for 26 hours a day to stay up to date? Of course, you should be using these reference points. So again, it's variation. And what do you think will get us to more consensus around this?
When I think of medicine, and why I went into medicine was my GP. So you asked a question earlier, what's gold standard medicine look like? I always imagine my GP. So he would wear like a tartan suit, sit on a radiator heater, just sit across from me, like there was no computer in the room.
Pocket watch?
Yeah. Very old fashioned, like all these old like ECG machines that was a pen on a paper that would do this is crazy. Anyway, so basically he was the purveyor of like intelligence. He would figure out what's going on. He would do all the diagnostic in his mind and then just give it to me in a nice, understandable patient plan. And that brand of medicine, there are good parts. So the good part is that his documentation was a cue card of my life, and he had every important thing that mattered to him in that cue card. And because he only was one GP in the practice, I would only see him. He didn't need to explain his history to anyone else, good or bad. Like that brand of medicine is, I think, what people imagine. It's like this platonic ideal of like one doctor that knows me and is in control of everything that's going on. So going from that to then what we do now, which is there's all of these different systems. Like most doctors, the default view is almost like a database of different information that you're trying to process and update as you're taking history and thinking of what to say next and thinking of what could be going on. It's just like a lot of cognitive overload. So what I imagine is, if we're doing our job, we will get doctors back to that platonic ideal where maybe the interface becomes like there's no database and there's just almost like an AI interface that's listening, that's surfacing data that matters, that's summarizing and retrieving things from the clinical research that it already knows that I don't know. So it's learned from my practice, like where it needs to step in, that, Tom isn't up to date on this because he's never prescribed this medicine. So maybe surface this study in that moment. But then if Tom's very strong in this other area, like don't intervene, he's got it, he's read the research, he knows what's going on. So sort of this like partnership hybrid, I imagine, of, like an AI can't feel a pulse. When I was a vascular surgery trainee, like the pulse decided whether you cut off someone's limb or not. Like it was quite important. The physical world mattered. So I think it's some combination of like this hybrid between AI systems, the doctor, put you back in front of the patient. Sure, there's notes, but there's other things. I think that's where it'll go.
Well, we're going to talk about embodied artificial intelligence at some point, because I think the robot might be able to feel the pulse. But before we do that, I want to get into some regulatory issues, because what you're talking about, where we've got the physician and they've got the system behind them that is getting more and more educated as it ingests information that may be clinical, might be social. It knows that Tom, this patient, has 4 cats, for instance,
Exactly.
And lives in Melbourne,
Exactly.
and is giving those sorts of prompts, but then maybe is also coming up with ideas related to next steps, coming up with ideas related to diagnostics, to potential treatment options. So all that is happening today. But across the world, we think very differently about the regulation that should be required around systems like this. Whether you call them clinical decision support systems or something else. What do you all think, given you all sit in different geographies, what do you think should be the right level of regulation for something like this?
Regulation is an eventuality as technologies evolve, and I think it's really important for markets and trust and consumers. For clinicians, it means that they don't have to shoulder the burden of new technologies and they can focus on delivering care which is appropriate. Having said that, because regulation is a phenomenon of mature markets, there needs to be some accommodation for how do we adopt and experiment with new technologies. And the pace of technology has never been faster than it is right now. So as I look globally, I see different regions with different regulatory postures, and I see the EU as the most regulated, but places like the US, of all the developed markets, being the most liberal. And so what that means as a global company, we can think about how do we actually test and experiment and get our claims and evidence in the more liberal markets, but make sure that we're designing for the highest bar. I support regulation. I want regulation, and I want to work for the company that approaches regulation as a safeguard for society and for the broad use and adoption of these technologies. And so that's the way we see it globally. The liberal markets versus the highly regulated markets, and then bringing this technology forward into mainstream adoption.
But then, Hannah, my concern with regulation, I'd love your thoughts on this, is that sometimes we can be overly concerned about technology. The technology must be perfect. Whereas we forget that human beings can come into work with hangover. Human beings can make mistakes. So what do you think is that right point of comparison? Is it to achieve perfection, and anything less than that means that we do not use this technology in healthcare? Or is it to compare it to a system that is primarily human beings that is, let's be honest, prone to making mistakes?
Totally. Yeah. And I think, like, to your point, Simon, like, regulation applied in the right way is good and supports, innovation and change. And historically, like, why have we even got regulation, right? It's come about because harm has happened to patients, right? Like thalidomide, like these disasters where we go, oh gosh, we need to rethink this can't happen. So in essence, it's good because it's preventing patient harm. But have we gone too far where we're so risk averse? I think we in a heavily regulated environment, we can be so focused on the kind of compliance process and forget it's not really about the compliance process, it's about the outcomes. Like, what is the effectiveness? What are we doing that's improving patient outcomes? We need to measure that, not just, yes, you're doing really well because you're following a process, right? And I think that we can sometimes reward inertia and sitting still, even though it's, we're not improving any patient outcomes on this front, but we're not changing because we're too scared to change. And I think a part of it is because we don't know what that benchmark is to start with. To your point, when I'm sitting in a GP room seeing patients, there's no way of anybody knowing whether I'm doing a good job, right? Nobody's monitoring me. Nobody knows other than, I do my annual appraisal, but nobody can see what I'm doing on a day-to-day basis. But yet to bring in machines and AI and technology, that has to be perfect. It has to be 100%. So we need to think about what the benchmark needs to be, to your point. Like, humans are not perfect and we will make mistakes. All of us will have made errors and mistakes in our clinical practice. So why are we making machines and AI, perform at the level of perfection?
I want to press actually on the example you just gave of thalidomide. You mentioned women's health. we have such little evidence and research related to pregnancy and women of childbearing age because of this.
Yeah.
So we can overcorrect. And that is my concern here with this technology, that the second the AI makes a mistake, it's going to be the front page of the New York Times.
Yeah.
And the mistakes made by human physicians on a minute by minute basis are never really discussed and talked about.
Yeah.
So maybe explain that example a little bit more, and then would love your thoughts on this potential overcorrection problem.
Yeah, absolutely. And I think also we've got to think about the fact that a lot of women's health, for example, we don't have a lot of data on. And why don't we have a lot of data on? We all know that women were not included in clinical trials until 1993, right? Like, we don't have that history, that historical data bank to be able to test out how things perform for women as they do for men. It's just not the same. And pregnant and postnatal women aren't entered into clinical trials, right? During pregnancy, it's not something that you would really want to have an experimental drug necessarily. So it means we just have no data on it. And I think that was, part of the problem in the 70s was there was a lot of experimenting, and that was sort of found to, the thalidomide crisis came about because of that. But I think it's a bigger problem around the data and how we have kind of data equity to support, equitable technology.
So this is a huge issue. Data interoperability or lack thereof globally. And I think companies like Heidi can be really interesting here, because in giving away these tools and having physicians use these tools in encounters, you must be developing an incredible just data set corpus of knowledge, where a lot of this data has been siloed across the world. Thoughts on this kind of AI kind of march that we're seeing now into the future? How does this issue around interoperability impact AI's ability to be successful? And then do you see your own company as having a role in making a difference here?
Yeah. Maybe just go back a little bit. So on the regulatory side, one other thing that I think is interesting is, so even just the medical scribe, like the documentation in the UK, is a regulated medical device. So we're already classified as a medical device, we're registered, we have post-market surveillance on all of the behavior of the notes, whether how reliable is it, are there dangerous hallucinations, all these kinds of things. And I do think it's kind of good and bad. So the good is that it forces a level of rigor and thoughtfulness in how you build the product. So you can't just ship an update, or you can't just change a model and suddenly you're getting dosages wrong or getting medicine names wrong. So I think that's good. Like, it is dangerous.
Isn't AI fundamentally iterative?
Yeah. So that's the hard part. So I think you have to iterate, and that's why you can have we call it Heidi Labs. So you can have like a population of doctors who know that they're in the experimental branch and they're getting constant updates all the time. But if you're in, let's say, a hospital setting where, you're being relied on every day, then maybe it's unreasonable to expect that those doctors are going to be constantly checking if Heidi's changed or the behavior's changed. So I'm not sure. I think there's a spectrum, like probably scribing for the most part. We've demonstrated in our own data that it's very safe. And yes, things can go wrong, but like with the right guardrails, doctors can understand that. They should check their notes. It's their notes. They're going to sign their name to it. In the evidence side of things, where like you start to visit influence a decision, my personal perspective is that it should head towards being a device. Depends exactly how it's used. Like if it's on its own and it's just a chat interface, it's probably okay. If it's strictly informational, probably okay. If you're really asking like a precise, like, what do I do next? That's probably at that point should be, maybe regulatory processes will change, but I think eventually people will realize that doctors will start to do what it says. And so you want that thing to at least be demonstrably safe or referencing correctly, not falsely creating.
Just to dig in there, do you think we're going to move into a future where the AI says, this is my recommendation? Or do you think it should be, here are 3 things that you could do? Option 1, option 2, option 3. And then each one the AI can assess the pros and the cons, and it's on the physician to make that ultimate choice.
Yeah, exactly. So that's what most of the systems do today. Like they'll just surface, patients who present like this. These are the different things they could have going on, but use your own clinical judgment. I think the doctors will lead us. That's what they want. Like they don't want their decision making intervened upon generally. And that's why, like, if you think about autonomy as a slider, like the maximum autonomous system that's, I don't know, completely unsupervised drafting investigations or something for Hannah to sign off, that's definitely a device, because if it incorrectly reads the referral letter and inputs the wrong investigations, the chances that Hannah reads every letter, the whole point of the product is she doesn't have to read the letter. So,
and it's unfair to ask, know, that we've just designed the system to make it really easy for you.
Yeah.
But now you have to do all this additional work to check that everything is accurate.
You're basically just passing the buck. You're like, oh no, we're not making the decision, but really you are. So I think it's just case by case. I don't think it'll ever be a reason to win. Like, you've got to build the best products. The doctors will lead us what they want, and then where there is real patient harm, that's why we'll always do the work and do the trials and, slow down our development, because that's, patient safety is at risk.
Yeah. But I think for like complex patients, it's going to be much safer to use something supporting you. I'm thinking of like my clinics where I'm seeing patients and I'm thinking
10 minutes.
Yeah. And I'm thinking in it, oh gosh, I know your series of symptoms line up to something I studied about at medical school. Can't for the life of me remember what that rare disease is. How many times have we done that before where we think, it is, they all link together. I just can't quite recall it. But we know that using AI and technology to support us, we'll be able to pick that up and support us in diagnosing a patient, agree that this needs to be, a medical device if it's influencing our decision making, but that will be super helpful in improving my productivity as a clinician. On the other side, to your point, Tom, like when I'm locuming as a new GP and I don't know which formulary I'm meant to be using because it's different from one practice to the other, that's a very quick and easy, we use amoxicillin in this practice as first line, for example.
And I think before we get any further, I do want to level set here around how accurate the technology even is. I've seen a lot of studies on this, and I'm just going to tell you, my mind has been blown recently in just how good it's gotten in such a short amount of time. And I've heard people say, oh, the AI is still in its infancy. It's like a screaming infant still compared to where this is all going to go. I've recently have heard from AI experts who say it's probably a little further along than that. Maybe it's an adolescent now, but we're really early, and yet the accuracy seems to me to be quite impressive. Simon, what are you seeing in terms of the accuracy with these systems and how it compares to a human physician?
It's worth remembering that the whole field of ambient voice technology has been a commercial phenomenon only since 2023. But the pace that these foundational models are improving means that within that 2-3 year period, we've seen incredible growth and capability. It's now to the point where I've gone around and I've seen a lot of the doctors that are practicing with the technology, and it's a heuristic that's very familiar to them. When I think about how I trained as a doctor, I was a junior, and then I would take the case history and I would then go relay that to my senior. And then when I became a senior, I had juniors presenting a case history to me, and my clinical acumen was to listen to that and then look for where the error points are. That's kind of what the scribe's doing. So it's a familiar heuristic, but the quality of the notes, you know it when you can see it. And because you were in that conversation, you can check against what's there on the page versus what am I reading. And the sense is that this is almost too good. You almost would like enough problems in there that you're cognitively thinking through, I need to correct this. But the notes are getting to be that good that the counter problem of automation bias means that we might just stop critically appraising. And that's the concern. So we want these notes to faithfully represent what was said in the consultation, but we also want people to take accountability for, yes, those are the notes, that is an accurate transcript of what happens, and return time back to the conversation. We've got specific statistics of error rates and all the rest of it.
Yeah, I think there's this problem where even consumers generally are getting not the best model unless they're paying for the most expensive subscription. So there's this constant mismatch between where the technology is at the bleeding edge versus the average, experience I would say that people have had. Again, this is just my own experience, but for the absolute best models with like the highest thinking budgets, there's no comparison in clinical reasoning to me versus that system. You know, like I was Dean's Honours List at the best university in Australia. Like I was good at clinical judgment, but it's not close. Like it waxes me any day of the week. And it doesn't matter. I could have my textbooks, I could read it, I could spend all the time. Most of the models are smarter than me in book intelligence, but I still think there's a gap in managing risk. That's the part, like the hands on the patient, like looking at the person, knowing them, seeing how sick they are, how they act in the room. But the idea that I wouldn't use this to support me feels a bit anachronistic or almost like irresponsible, that you wouldn't be using these tools to support your reasoning. We just have to demonstrate it. That's what we do for people who are creating tenders or creating procurement setups. We just show the data and be like, actually, you know, hallucinations like aren't actually as significant as you think they are. The biggest risk with ambient is actually the transcription. The voice is hard. Even if I sat there listening and typing the words out, I would make mistakes. So our transcription is actually better than that. It's incredible because it's trained on captioned text. So where someone knew what was being said. So it's actually like super hearing. But even still, sometimes things go wrong. So that's really the root of all errors, is almost always the transcription. Very rarely the model making a mistake these days.
Okay, so I'm going to tell you guys a funny story. Or at least I found it funny. I was recently in San Francisco, California, and a physician friend of mine, they have Waymo in San Francisco, which is the self-driving car. And we were standing outside a restaurant, and he's just standing there for ages. My Uber's already on the way, 2 minutes out. And I said, why are you still waiting? He said, because I just ordered a Waymo. I really wanted a Waymo. And I said, why do you want a Waymo? It's 15 minutes. My thing is 2. And he said, I just feel safer in the Waymo, which is entirely self-driving, fully autonomous, no human being. And it made me think about the patient side of all this, that now a patient might be a bit wary if somebody says, you know, we're in a consult, can I take a recording? I'm going to use a scribe. But in the future, I could imagine a scenario like that where the patient wants these technologies because they feel safer, just in the same way that that physician feels safer in the Waymo. Do you, as practicing physicians, all of you, do you see that change happening now?
Yeah, totally. We've all been to a GP appointment or a clinic appointment before where the doctor's turning away and going, sorry, what did you say there? Oh, yeah. You know, and it's not a great experience from a patient perspective, is it? And it's not from a clinical perspective either. And what we found from the studies that we've done, you know, external evaluations, we found that our patients love it. They feel more listened to. They feel like you can make better eye contact. It just allows the clinician to really focus on that kind of human side of medicine rather than doing all of the admin stuff. So I think that they feel more part of the consultation as well. So when I'm examining somebody, I'm talking them through and saying, oh, I'm listening for this sound, or, you know, I'm just going to speak out loud to speak to Heidi. I'm feeling your tummy. Oh, it's not tender. Is it tender over here? Is it tender when I press in or let go? All of these things mean that the patient is taken on the journey a lot better, and they really like that. But I think, to your point, the trust, and in the future, I think it will become more than that. I think it will be, actually, I don't know if I'm going to trust you as my clinician if you're not using these types of tools, you know, whereas historically it was completely the other way.
Yeah, I know anecdotally from some of the Heidi users that there are patients who ask at the practice to go to doctors that use the tool. So it's already like starting to happen because they prefer the visit. It's just like more focused, exactly what you said. Yeah, and the examination is my favorite part. It's like, oh, you're actually doing something.
Yeah.
You know, it's like, yep. You know,
it's a proper shared care consultation, isn't it?
Exactly,
you know, which is what we're taught to do.
Like listening for different sounds.
Yeah,
because usually patients were never brought into what was happening up here while you're doing the physical bit.
No. And they leave and they have all these questions and think, oh, I should have asked that, you know, whereas now they leave, they can read their note. It's a comprehensive note for them, you know, to have at home in their NHS app or whatever. You know, I've got some of the consultants, a respiratory consultant that goes through his Heidi note with the patient at the end of the consultation and says to them, have I missed anything? You know, it's just a wonderful way to like have a shared interaction with the patient.
So in the old days, Simon, it used to be that a patient would walk in and they've done a bunch of Google research and they'd say, here's what I found out on Google. And a physician might say, groan, you know, like, oh no. nowadays it's with AI. Has that changed anything, do you think, for the physician when you've got this really informed patient walking into a room who's already uploaded their records, scans, imaging, everything onto an AI system and has their notes through some of these new tools that we're seeing that Heidi and others are producing?
Yeah, so it's still happening. And that has been a challenge because there's an asymmetry of information in healthcare. Either it's the clinicians themselves who have the information or the organisation that owns it. And not just the information, but they understand the context and what that means. And that led to a paternalism in the doctor-patient consultation. Now, there's less of an asymmetry of information. You have your own information increasingly, and you have tools that help you understand what that information means. That's a good thing. We're up-leveling health literacy in our society, but it creates a different dynamic in the consultation, especially if you're time pressured and you need to work against that. So the consultation becomes less about you tell me everything and then I'll tell you what's going on and what to do about it. And it can become a bit of a coaching dynamic, but it does result in some alarmism. So I've got these 3 symptoms. I popped it into AI, and I'm quite sure I've got brain cancer. Some of the interventions that you're going to be doing have risks in and of themselves. So clinical judgment actually needs to sit with the clinician. That's why we go to university, and that our judgment is the service that we provide.
I think that sometimes my role is perceived as being very different now. So rather than being a guide to your complex health problems, I'm kind of seen as this like gatekeeper that my answers then need to be verified. Do you know what I mean? So it really changes the way that the patient views the doctor and that you interact with.
Yeah, the patients come in and said, AI's already told me that I need this additional set of tests, so you are the necessary step towards me getting the outcome that I want.
Yeah. Exactly.
You're sort of connected to the rails that has the medicines.
Yeah, you're not seen as like the knowledge base at all, right?
Yeah.
And I think that can be challenging to navigate, particularly if perhaps, clinically it doesn't align and you don't agree with that plan. Trying to then communicate that to them and helping them to navigate a different path, which would probably be more effective for them, I think that's really quite challenging.
Yeah, I really agree with that part. So it's similar to what I was saying earlier. The models that the consumers get aren't as good as the most intelligent models that maybe we would use in a clinical setting. And I've had this experience myself, like with my own symptoms, where either I know the answer or it's a test set we're running. If you're using a cheaper, faster model, which very often you'll get on ChatGPT or Anthropic by default, it's actually not as good as the doctor. Like it's not on that frontier end, and it's getting like weirdly over-anchored to the symptoms that you put in first, and then you're getting like the wrong answer, and it's being a bit sycophantic, and it's like telling you. The
sycophantic thing is so funny. I have this joke where I'm like, it's, everything is like, you're not just a genius, you're a visionary.
Exactly.
And treats you that same way about healthcare.
And it's like, oh yes, this is really concerning. Like I am really worried about this. And it kind of like self-enforces like the wrong path. But I think it is net good. It's just, I suspect this is where like one day we will go into this more consumer side. I think if there's some authenticated channel, like if, all your patients could just chat to us about the issue, or at least something built for health that avoids these pitfalls, I think it will do better. It's the same as Google. It's just almost like more powerful in a way now.
Yeah.
Because now you can really go down a rabbit hole and it will like reinforce your misconceptions and beliefs in a way that the normal search wouldn't have. So it's a bit tricky. Like it's good and bad. It's good. Yeah. Information is always good, but it can be dangerous.
We are at a moment now that it feels like we're on the precipice. We've seen, you mentioned some of these companies, whether it be Anthropic, OpenAI, starting to announce formalized healthcare products and services. So that's happening. And the big news of the moment is the state of Utah in America just said that a venture-backed company called Doctronic, for a very, very limited use case, which is medication refills, can function fully autonomously. And of course, this isn't happening tomorrow. Plenty of work will happen behind the scenes where the human physician and the AI model will be training simultaneously to the point where the accuracy is there, whether it be 100% or 99%, but the accuracy is enough to be able to say, let's start to use this fully autonomously in this one state, in this one use case. And some physicians that I've talked to think this is obvious and great. None of you three want to be doing prescription refills. And then there are, of course, those that feel very nervous about the direction that this is moving into. In some cases, privacy, in some cases, accuracy, in some cases, my salary. You see all flavors of reactions to this news. So I'm going to put all three of you on the spot to get your thinking. When you read this news, what was your knee-jerk reaction to this? Want to kick us off, Tom?
Sure. Yeah, I thought they beat us to it. Yeah. I think it would definitely happen. Repeats is an interesting scenario because I think it's uniquely placed as something that models can do well, because you've got the history, you can read about, someone's been on this medicine for a period of time. It's also a good one for deterministic guardrails, because you can say, like, they have to have been prescribed this medicine a certain number of times, only these medicines that are not harm-causing. And I think I'd be interested to get your perspective. Like, I think of the times I've gone to the GP and had a refill, and I've never been asked a question, like maybe once, or my wife as well. And there are reasonable questions to ask. So I suspect that AIs will be better, actually, like more thorough. They'll uncover more side effects, more problems than the doctor would, because they're not constrained by time. You're not rushing it in as the fifth thing on the way out of the clinic visit. I think how you do it is interesting. Like, I see it as, if we ever do these things, it'll be allied to the practice. Like, they can set it up for the practice, and it's like an extension of the services we offer. I don't love the idea of this being like a replacement for the practice, because, it's like, okay, in the case of Doctronic, like, are they the provider then? Or is it like, are they trying to replace the whole healthcare system? Like, this, are we going to end up with 50 services that can do like certain things they've been approved for? I'm a fan of the hybrid, like the mech suit for the doctor. Like, there's certain things that the AI is doing for them, but it's like my herd of Heidis that I'm monitoring, that are managing my patients all the time, tending to them, making sure they're at less risk, they're getting the care they need when I'm busy, doing something more high leverage.
Yeah. I think my gut was of concern when I first read it. So I thought I just couldn't see how it was going to play out. But when I kind of, read between the lines and read more about it and realised it was actually, for chronic patients who are on repeat medications, it felt a lot safer. But I can see why it would cause a lot of apprehension. And I think there's a lot of, to your point, like protectionism, that clinicians are nervous about this. And where does that leave us? What's our role in this, etc. So but I think it will come down to how we deliver it. What are the guardrails around it? What are we prescribing? What all of the sort of safety and governance around it. I think that, when we're prescribing these repeat medications, to your point, Tom, sometimes we'll forget to ask questions that we should be asking, or sometimes we'll forget to be reminding them to do their annual blood test. This isn't going to be forgotten when it's a machine doing it. However, what I wouldn't like to see, what we have seen historically in healthcare, is that when you're implementing these types of changes, is it can increase your workload for the clinician. It can push it back onto us, because it doesn't want the responsibility. So
it's like review every single conversation.
Exactly.
And assign your name to it.
Exactly.
It's 10x the number that you would have otherwise.
Exactly.
Yeah.
So that's where we need to be careful, I think.
When the news came out, I knew it was inevitable. The question is, where and when. And so I wasn't surprised it was in the US. I was surprised that it emerged this early in the game. But to your point, Hannah, I drilled into the use case and realised that's actually part of the friction in healthcare. That's part of the noise that keeps clinicians away from doing what clinicians do best. The reason why it's newsworthy is not that we've got autonomous prescribing, because the use case is quite narrow and low risk. The news is, what does it mean for the role of the clinician going forward? I think that's the really interesting thing. And this is a task that is uniquely done by a doctor, and they apply their doctoring knowledge to come up with that. prescription, even if it is a repeat of a medication for someone with a chronic disease, are we more than just a sum of tasks? What is our role? Yeah. And I think it makes sense to start tiering off those functions that can be safely delegated to technology or even other workers so that we can practice at the top of our license and maximise the scope of care. And when I look at the workforce challenge, the overwhelming demand of healthcare and the limited clinical resources we've got, we should be applying those clinical resources to the highest value tasks. So this is a good thing. But I understand why people are challenged, because it's not about this, it's about the next step and the next step and the next step.
Like I personally worry about these limited kind of like the classic US healthcare companies where you have like a clear ROI model, you pay for the prescription, amazing. We can now do these autonomous repeats. But those repeat prescriptions are opportunities for primary care typically. Like that's when you have to go see the doctor, and then you're like evaluating, like, does this person really need to be on a statin, or should we order some more cholesterol tests? Their lifestyle's changed, they've started a Ep.1, whatever. So like I think that the end state will be some autonomous tasks, but you have to have the ability to think like a clinician would. So when I'm taking that history and doing the repeat, there may be other questions that get asked, and then maybe it's Heidi reading the record and summarizing other things and being like, oh, actually in this case, I'm going to send a note back to your doctor because I think it's not appropriate. So I think these it's more complex because it's less sexy. It's less like, oh, it's just an autonomous prescribing thing with these 80 medicines. But this like sort of trying to play partner, I think, is going to be the way that you actually get there. Now, we still will have to prove that we're a device and we're safe and we have these medicines we can prescribe for. But the goal of it is not to pop out a medicine, because then you end up being a pill mill. Like that business is incentivized to prescribe. So they'll never check if the statin is necessary or not, because they get $4 for every statin that gets printed. Whereas if the incentive is, I'm just trying to assist the doctor here, I'm trying to provide best care, then yeah, maybe there's sometimes 5% of the time the patient won't get their prescription, but they'll still get that primary care moment that they would have otherwise had if this system wasn't there. But it is more complicated and less easy to sell. Yeah.
And I think as somebody living in the US too, who studies these topics, for me, it was billing, reimbursement, those sorts of questions, because our whole system of billing and getting paid in medicine was built around human beings administering the care, which is fundamentally a scarce resource, as we've discussed. The idea of AI doing it means that suddenly this resource is abundant. So how do you pay for it? And I think that is one of the big questions that we have to tackle on a global scale. But we're running out of time, so I want to ask each of you one final kind of rapid roundtable question that I love to do, just to put people on the spot. And that is to ask you, if you had one word to describe your feelings about the future of AI and medicine, what would it be? And of course, I'm putting Tom on the spot first.
Audacious. I think it's going to be, it requires ambition and excitement, but care. So I don't know, it feels like I'm an explorer at the beginning of like some uncharted territory that we're about to go on.
That was about 5 words.
Yeah, sorry. Audacious. Yeah.
Audacious. We're landing on audacious.
Exactly.
Okay, I love it.
Yeah, I mean, I kind of want to say the same, like pioneering, at the forefront. I won't say any more words.
I think you're right. It's going to take visionary, pioneering thinking.
I think access, and it's not a verb, but as we write the health equity challenge we've got and the limited access to those scarce resources, access, I think, is the number one thing that this technology will do.
What's yours, Christina?
I think it's experimentation, not something that healthcare is great at necessarily, but we're going to have to start experimenting, and we're going to have to start finding better ways to study these things over time. And then I think part of the scientific method is being open to being wrong.
Yeah.
So I think that would be my word. But yeah, thanks everybody for joining me today. I think we didn't necessarily agree on everything. We agreed on most things. But I think we came to a conclusion that some of the biggest challenges and questions that we face really relate to things like physician shortages, privacy, safety, accuracy, and how we can fundamentally move into a future where the physician the patient and the technology are all working in alignment. And I think that we have an immense opportunity ahead of us for the first time in really decades. So thank you, everybody, for this amazing conversation.
Thank you.
Nice to see that.
Thanks, Christina.
Next time, we'll come together to unpack capacity collapse. With clinicians already stretched beyond capacity, how do we support care delivery, and what role can AI play in easing the pressure safely?